Health authorities in South Africa and the World Health Organization have launched an urgent international response following the identification of a hantavirus cluster linked to a Dutch-flagged cruise ship, the MV Hondius. This development marks a significant public health event, as it is the first time a hantavirus strain has been confirmed in South Africa, a region where the virus is not endemic. The investigation began in earnest on May 2, 2026, when the United Kingdom's National International Health Regulations focal point notified the WHO of a cluster of severe acute respiratory illness among passengers. The timeline of the outbreak traces back to early April, when the vessel departed from Ushuaia, Argentina, carrying 147 passengers and crew members of various nationalities. The primary concern for health officials is the identification of the Andes strain of the virus. Unlike most other hantavirus variants, the Andes strain is documented for its rare but critical capability for human-to-human transmission. This specific strain is endemic to parts of South America, including Argentina and Chile, where it is typically transmitted via the aerosolized excreta of infected long-tailed pygmy rice rats. In this instance, the infection appears to have been introduced to the ship by a 70-year-old Dutch national, identified as the index case, who developed symptoms of fever and gastrointestinal distress on April 6 while on board. His condition rapidly deteriorated, leading to his death on April 11 before microbiological testing could be conducted. The gravity of the situation escalated when his wife, who had been in close contact with him, went ashore at St. Helena on April 24. After boarding a flight to Johannesburg on April 25, she collapsed at OR Tambo International Airport and died the following day. Her death, initially unexplained, was later confirmed via polymerase chain reaction testing to be caused by the Andes virus. This sequence of events has triggered an intensive search for passengers, airline staff, and medical personnel who may have been exposed during the transit of infected individuals through international travel hubs. The risk to the general public in South Africa is currently assessed as low, as the local rodent population is not known to carry the Andes strain. But the high mortality rate of Hantavirus Pulmonary Syndrome, which can reach between 40 and 50%, has placed frontline medical teams on high alert. The core of the epidemiological response is centered at the National Institute for Communicable Diseases, or NICD, in South Africa, where scientists successfully identified the rare pathogen in what officials described as finding a needle in a haystack. Professor Lucille Blumberg's team at the NICD achieved a breakthrough by confirming the infection in a British national who had been medically evacuated from Ascension to South Africa on April 27. This patient, currently in stable condition in an intensive care unit in Johannesburg, provided the critical samples that allowed for sequencing and metagenomics to confirm the presence of the Andes virus by May 2. This laboratory success was vital because hantavirus is not routinely tested for in South African clinics, and its initial symptoms, fever, muscle aches, and abdominal pain, closely mimic more common illnesses like influenza, COVID-19, or malaria. The international dimensions of the cluster are expanding as contact tracing reaches across borders. As of mid-May 2026, 11 cases have been reported globally, including 3 confirmed deaths. Confirmed and probable cases have now been identified in the Netherlands, Switzerland, France, and Spain, involving passengers who disembarked from the MV Hondius and traveled home before the onset of symptoms. In one instance, a male passenger flew through South Africa and Qatar to Switzerland, only becoming symptomatic after arrival. The South African Department of Health, led by Minister Aaron Motsoaledi, has confirmed that 97 individuals are being monitored as potential contacts within the country. This group includes 32 healthcare workers who treated the patients in Johannesburg clinics and hospitals, as well as 9 security guards and several port health officials. The focus for these medical teams is the transition from the initial prodrome phase to the cardiopulmonary phase. During this transition, which can occur within hours, the virus causes a sudden drop in blood pressure and severe fluid accumulation in the lungs, leading to acute respiratory distress. Because there is no specific antiviral treatment for the Andes virus, clinical management is strictly supportive, relying on early mechanical ventilation and intensive care to manage the severe inflammatory response. The NICD has categorized the infection as a Category 1 notifiable medical condition requiring any suspected case, defined by fever and respiratory distress within 6 weeks of exposure to the ship or infected passengers, to be reported to health authorities within 24 hours. Prevention and surveillance efforts are now focused on the mandatory 6-week monitoring window, which corresponds to the maximum known incubation period for hantavirus. Of the 97 contacts identified in South Africa, 90 have already been reached and advised on self-isolation and symptom monitoring. While one contact in the Western Cape recently reported symptoms, preliminary tests for the virus returned negative, and officials state that no secondary local infections have been detected to date. Public health guidance emphasizes that while hantavirus is a zoonotic disease typically contracted through the inhalation of dust, contaminated by rodent urine or droppings, the current outbreak's reliance on human-to-human transmission is a rare occurrence specific to the Andes strain. Health agencies are using this event to stress the importance of rigorous infection control in clinical settings when treating patients with unexplained respiratory failure, particularly those with a history of international travel or maritime exposure. The NICD and the World Health Organization remain cautious, noting that the limits of current knowledge regarding the efficiency of human-to-human transmission mean that close, prolonged contact is the primary risk factor. There is currently no evidence that the virus has entered the local environmental cycle in South Africa, and officials have moved to allay fears of a wider community outbreak, noting that the virus does not spread as easily as SARS-CoV-2 or influenza. However, the financial and logistical pressure on the National Health Laboratory Service has been highlighted by Parliament as a key concern for maintaining this level of surveillance. As the monitoring period continues into June, the international medical community is watching the Johannesburg cases for insights into the clinical progression of the Andes strain outside of its native South American habitat. For now, the focus remains on the recovery of the hospitalized patients and the completion of the contact tracing protocol to ensure the cluster remains contained. This report will be updated as the NICD releases further sequencing data. For more on emerging public health reports, consider subscribing to this channel. The clinical core of this crisis shifted from the decks of the MV Hondius to the high-pressure environment of South Africa's intensive care units, where a devastating secondary wave of infections has now been confirmed among the medical staff. The National Institute for Communicable Diseases, or NICD, reports that what began as a containment effort has resulted in several healthcare workers contracting the Andes virus strain while attempting to save the lives of the initial passengers. These hero medics were exposed during the highly invasive procedures required to treat Hantavirus Pulmonary Syndrome, a condition where the lungs rapidly fill with fluid, necessitating emergency intubation and the use of mechanical ventilators. In the chaos of the initial admissions, before the rare South American pathogen had been identified, the standard level of personal protective equipment was insufficient to block the unique human-to-human transmission capability of the Andes strain. Laboratory analysis led by Professor Lucille Blumberg has since confirmed that the virus was likely transmitted via fine mist aerosols generated during the resuscitation of the Dutch index cases. The diagnostic breakthrough that finally identified the pathogen occurred at the NICD's specialized biocontainment facilities. Using a combination of metagenomic sequencing and high-sensitivity polymerase chain reaction tests, scientists isolated the viral RNA from the British national who had been evacuated to Johannesburg on April 27th. The laboratory work was described as an exhaustive search, as hantavirus is not a pathogen typically screened for in the southern African region. The confirmation of the Andes virus, specifically the strain endemic to the Patagonia region of Argentina and Chile, stunned the medical community, as it marked the first recorded instance of this virus causing a cluster on the African continent. This identification was critical for the infected doctors and nurses, as it shifted their treatment protocols from generalized sepsis management to the specific, albeit limited, supportive care required for hantavirus. Because there is no known cure or specific antiviral medication for the Andes strain, these medical professionals are now fighting for their lives using the very same technology they were operating for their patients, including extracorporeal membrane oxygenation, or ECMO, which serves as an external heart and lung to allow the body's primary organs a chance to recover from the massive viral insult. The scale of the exposure within the clinical setting remains a primary concern for the South African Department of Health. Minister Aaron Motsoaledi has confirmed that the investigation into these occupational infections is focusing on 32 healthcare workers who are currently classified as high-risk contacts or confirmed cases. These individuals include trauma surgeons, ICU nurses, and respiratory therapists who were present during the first 72 hours of the patient's hospitalization. The data indicates a brutal progression for the infected staff. After an initial incubation period of 1 to 3 weeks, the onset of symptoms begins with a sudden high-grade fever and intense muscle pain, particularly in the lower back and thighs. This is frequently followed by a crash into the cardiopulmonary phase, where the vascular system begins to leak, leading to a precipitous drop in blood pressure and catastrophic respiratory failure. The NICD is currently analyzing whether the viral load in these secondary human-to-human transmissions is higher than in traditional rodent-to-human exposures, which could account for the rapid decline observed in the infected medical team, in tandem with the clinical crisis in Johannesburg. International shipping and aviation data are being used to trace the path of the virus across the globe. The MV Hondius, the vessel at the center of the outbreak, remains a focal point for environmental testing as authorities attempt to determine if an active rodent reservoir existed on the ship or if the outbreak was purely sustained by the initial index case. To date, 11 cases have been verified globally, spanning the Netherlands, Switzerland, France, and Spain. The logistics of the outbreak are particularly complex because many passengers traveled through major international hubs, such as Doha and St. Helena, before the severity of the situation was understood. The South African National Health Laboratory Service is working in 24-hour shifts to process samples from airline staff and airport security personnel who may have had contact with the Dutch national's wife before her collapse at OR Tambo International Airport. The focus remains on the window of May 2, when the virus was first officially identified, as any individual exposed prior to this date would now be entering the most critical phase of potential symptom onset. The state of the infected doctors in Johannesburg is currently described as critical but stable, as the international medical community monitors this unprecedented cross-continental transmission event. As the surveillance period for this unprecedented outbreak moves into its final critical weeks, public health officials are focusing on the stringent monitoring of 97 primary contacts within South Africa. Under the guidelines established by the National Institute for Communicable Diseases, this 42-day observation window is the gold standard for ensuring containment, as it accounts for the maximum known incubation period of the Andes hantavirus strain. The status of the virus as a Category 1 notifiable medical condition remains in effect, meaning that any physician or laboratory identifying a potential case is legally required to notify the Department of Health within 24 hours. For the public, the practical takeaways are clear. While the risk of a general community outbreak remains low due to the absence of the specific long-tailed pygmy rice rat reservoir in local South African ecosystems, the risk of human-to-human transmission requires heightened vigilance among travelers and medical staff. Health authorities advise that anyone who has been in close contact with individuals from the MV Hondius or who has recently returned from the Patagonian regions of South America should monitor for a specific progression of symptoms. This typically begins with a high fever, severe muscle aches, and significant fatigue, often followed by a sudden onset of shortness of breath. Unlike common respiratory infections, hantavirus rarely presents with a sore throat, runny nose, or earaches. Instead, it is characterized by its rapid transition from flu-like symptoms to acute respiratory distress. In terms of broader prevention and public safety, this event has prompted a global review of maritime health protocols. The World Health Organization is currently evaluating new standards for the early identification of viral clusters on cruise ships and the management of medical evacuations to non-endemic countries. For individuals living in or traveling to areas where hantavirus is endemic in rodent populations, the guidance remains focused on environmental hygiene. This includes the use of masks and disinfectants when cleaning areas where rodent activity is suspected, as the virus is most commonly transmitted through the inhalation of aerosolized excreta. However, in the context of the Andes strain seen in the current South African cluster, the emphasis has shifted to hospital-grade infection control. The South African Health Department is now implementing enhanced training for frontline clinicians on the use of high-efficiency particulate air, or HEPA, filtration, and N95 respirators during any procedure that might generate aerosols from patients with unexplained pulmonary edema. These measures are designed to prevent a repeat of the secondary infections that have devastated the medical teams in Johannesburg. There remains a significant degree of uncertainty regarding the exact biological mechanisms that allow the Andes strain, and no other hantavirus, to move between humans. And this remains a primary focus for international virology labs. The ethical and social implications of this outbreak are being felt deeply within the South African medical community. The sacrifice of the healthcare workers who contracted the virus while providing life-saving care has sparked a national conversation regarding the adequacy of support for those working in high-risk infectious disease units. As these hero medics continue their recovery in intensive care, officials are stressing that the best way to honor their efforts is through calm, evidence-based responses rather than public panic. The surveillance data indicates that the window for new cases linked to the initial April and May exposures is narrowing, providing a cautious sense of optimism that the cluster has been successfully ring-fenced. The South African government has committed to full transparency, promising to release the final findings of the environmental investigation into the MV Hondius once the vessel's origin point and transit history are fully reconciled with the genetic sequencing of the virus. The limits of current knowledge mean that while the